Hello, and welcome to our evening on winter sports. So we're going to have two speakers tonight, Professor Brian Devitt and Luke Fogarty. I'm Fiona Roach. I'm the General Manager here in the Sports Surgery Clinic. Anyone that doesn't know us, we're in Santry in Dublin, about 10 minutes from Dublin Airport, just off the M1 and the M50. We've over 100 beds. We do all surgeries here, from knee replacement, hip replacement to finger surgery. So all your MSK surgery we do here, including spines. So we have 3 MRIs and 1 CT and 7 theatres. So tonight, as I said, we're going to talk about injuries with winter sports. Brian Devitt will join us, as will Luke Fogarty. So what you can do, you'll see the tab there for Ask a Question. So put in questions there and we'll endeavour to answer them. And we'll be joined live by Brian and Luke. So they'll answer them for you after the presentations. There's also a tab there for about UPMC. So Sports Surgery Clinic is part of a group. So we're UPMC Sports Surgery Clinic. There are 3 other hospitals, one in Kildare, one in Waterford, and one in Kilkenny. And there are various sports medicine centres across the country. So if you want to go in that tab because you're further away than Dublin, you can go in there and see if there's anyone you can see for your sports injuries or any kind of orthopaedic care. And those hospitals also don't just do orthopaedics, they deal with other specialities as well. So first tonight, we're going to be joined by Professor Brian Devitt after his presentation. And Brian is talking Après knee, which I think is self-explanatory. And I'll join you then as well. Thank you.
Good evening. My name is Brian Devitt. I'm speaking this evening about ski-related knee injuries. And so it's a great pleasure to be able to join you again. So I just want to share a quote which I heard from one of my mentors when I started off my fellowship in Vail. So this quote was, if you're to design a device to rupture an ACL, you couldn't get much better than a ski. And this relates to the fact that with skiing, your knees are very vulnerable to turns because you've got a long lever, which is the ski, and you have your ankles are held in position on your skis. So Dr. Richard Stedman was one of the forefathers of sports orthopedics, and he worked in Vail, Colorado, which is a good place for ski injuries because it was at the foot of a ski mountain. So I like this particular picture, which one of my colleagues sent me, and perhaps we should all wear these when we're starting off. But really, ski slopes are the conveyor belt of knee injuries and other injuries, which we dealt with in this series of talks. And they are so because they become hugely popular. Back in the day, skiing was was for only the mega wealthy, but nowadays most people go on a ski holiday or have access to it, and they've become hugely popular. But they are risky sports. In this little schematic, we see that skiing has great preponderance of knee injuries, whereas snowboarding, yeah, you can get more kind of upper limb wrist related injuries. It's just due to where the board is attached to the legs. But also the single board with the snowboard is less risky than the isolated skis on each limb. In terms of the equipment has changed markedly and changes year on year, in fact. But back in the day, you can see these guys, no helmets. Essentially the planks were lashed to the ankles, and there was very primitive kind of footwear. But nowadays we have much more sophisticated equipment. You'll see the boots have got these bindings which hold your foot in this flex position, and the ski boots are then bound to the skis. And this is one of the critical things, is that when we're starting off to ski, what we really need is a very loose or a loose enough binding so that if you fall over, that your boot comes away from the ski and you don't use your ski as a lever, because that's where you get a lot of knee injuries. So a lot of people come to the ski rental place and they're very full of bravado from the previous year, and they say that I'm an expert skier now because I've skied for 1 week. But what happens is the ski technician is actually tightening what we call the din on your bindings to make it more difficult for your boot to come away from the ski. And as a result, you're more prone to knee injuries. So if I were to offer any advice, I would say go low on the din, or just say be truthful about your level of expertise, because that's how the binding is set. We also know that the skis have changed quite markedly, and the skis are essentially make it easier for us to ski. You don't have to lift your foot as much, and it's a lot about just how your weight is distributed, but they've really improved safety. The terrain and conditions are really important. So this is an example of very deep snow where you have to lean back on your skis to get purchase. But also, and the opposite is true, when you're very icy snow, you have to lean forward more. So really, the terrain and conditions really determine, how frequently people are injured. And often, when people aren't familiar with different conditions, that's when they have greater chance of getting injured. So if you're not familiar with the terrain or how to ski in a particular terrain, it's probably best that you would speak to an expert or have some lessons. And also be cautious when you're finishing a run of the day is when you go down the blue slopes or the green slopes and there's lots of people around. That's where you can really run the risk of getting injured because it's the traffic, but also the snow is very slushy and tends to be more sticky, and that's where people come a cropper. So this is probably an example of what the ski conditions are like this year, and you have to be really cautious where there's exposed rocks or where you've got grass exposed because it can stop the ski sliding. So in terms of the mechanism of injury, so previously when I've done this talk, I've done a diagram, but I thought it was easier to show this video. And you see a guy skiing down a pace down the mountain. And that snap you hear is not the snap of his ski releasing, but the snap of his ACL. So you watch the person, he's in deep slow, leaning back, back, and his knee is not in control. And it's his lower ski there that it twists and he twists on that knee and he's ruptured his right ACL in this setting. So if you have friends like those who need enemies, laughing at his buddy, but you can see very slowly he's leaning back. The knee was a deflection and what we call valgus. So he's really put a lot of stress in his medial ligament. And this is the classic injury pattern we see with knee injuries. So but we can't legislate for stupidity. And this is another source of frequent knee injuries as well, is that people just getting a bit carried away, maybe a few schnapps at lunch or a bit more of the red wine that doesn't really compute with the cerebellum when you're skiing. So in terms of how do we manage on the mountain? Well, first of all, we do no harm. That's the tenet of orthopedics and medicine in general. I always use the phrase "stay in your lane," and they put up these signs for a reason because they don't want people to ski beyond their limits. And it's not so much at the start where it looks nice and flat, but it's somewhere down the slope where you can really get yourself into a bit of trouble. So I'd recommend when you're starting off that you get lessons and you stay in your lane and go with a guide if you're unfamiliar with the mountain. But other things can be hazardous. It's the people around us. It's the fact that there's alcohol being consumed, and you have people who don't really have any regard for those around you. And I think that's very important. Just to be aware that it can be a dangerous sport, and you just have to be a little bit cautious. I would suggest return to your comfort zone. So particularly when you're starting off on the first day, we used to have a phrase in our family, you get your ski legs, and you really need to just to go up and do something gentle to begin with and not start off on a black or double black diamond unless you're very familiar with the activity. So how do we manage then in the clinic? Well, in the clinic is where the dust has settled, and that's really where we have the opportunity to make a very safe and informed decision as to how to manage the patient. And it's the same way we manage any ski injury. But the recommendation I'd have to people is if you are injured on the mountain, what you need to do is get a diagnosis. So you go down to the local medical tent. They'll very experienced people there. Typically, they'll probably do an X-ray, or maybe if they have access to an MRI, and they'll take a history of what the injury is. And if you hear a pop and your knee twists and you've got a swollen knee, well, the chances are you've had an ACL injury to begin with. So it's very important that a thorough history is taken. In terms of doing a history, we just need to take our time and get the right history. But if you have that pop and swelling, that's effectively you're an ACL injury until proven otherwise. The clinical examination is key, and afterwards you'll see the example that when you take your salopettes off afterwards and you'll see a big swollen knee, well, that's a bad sign, unfortunately. So the chances are you may have had an intra-articular injury, which is an ACL rupture or maybe a ligament rupture. So if that happens, you really need to think seriously about getting that assessed. In terms of management, we have to look at both sides as well. And just to isolate one limb, you're going to miss the other side, which gives a good example of normal. So be sure that if you're being examined by someone, that they expose both legs properly to have a good look. And if they're not doing that, you probably need to get a different assessment. They typically would do x-rays. X-rays can be somewhat helpful if you have this little flake of bone here that can diagnose an ACL, but some people use ultrasound, but it really is not, nothing compares to an MRI scan at the end of the day for diagnosing ACL injuries. But sometimes be cautious about what the quality of the MRI scan. If you're shipping up a magnet to the mountain, they're not going to always have their premium MRIs up in the mountain. So sometimes it's best just to, get diagnosed, go down to a bigger city or town and have a proper diagnosis, or come home and have a diagnosis. That's we've got very good scanners here and get it done very easily. In terms of the next step, and then it's really referral. So when you get home, if you're injured, you need to see an orthopedic surgeon quickly. And we're very happy to facilitate people who haven't got scans. We can get scans the same day. And then we're dealing with the issue in the cold light of day. So early diagnosis is much better than early treatment necessarily, and if the treatment is not appropriate. And one of the things we really need to do is we need to make sure that someone is appropriately managed. A lot of times, if people are away, there's this pressure to get treated early, and really there's no urgency unless there's a neurovascular injury to the leg, the blood flow has been interrupted, or very serious knee dislocation to treat this urgently. Most of these can be treated down the line. So it's important just to be calm about this and just get home appropriately and be treated then. In terms of non-operative versus operative intervention, well, that's the first thing we look at is, can we avoid surgery in a lot of situations? And I'll give you an example in the cases below where surgery is not always indicated. We want to remove the splints as soon as possible. A lot of people are put into splints, and I will be honest in that the medical companies over there, they make money from splints. So you get 200, 300 euro cost for a splint, but oftentimes they're not necessary. Now, if you have a medial ligament injury, a splint may be helpful for pain relief, but really we need to get those knees moving. So we try to take the splints off as soon as we can. And you'd never go into surgery with a person who doesn't have a full range of motion. So range of motion is really critical prior to any surgical intervention. We also want to get people weight bearing as tolerated, and we get them using crutches. And they often have a series of fancy crutches when we see people in this time of the year. But really, we want people to weight bear once they're able to do so, because that's good for the cartilage. It's good for restoring the normal biomechanics of their knee, and also great for the range of motion. So I'm going to go through a few little common scenarios. These are a number of cases which I frequently see at this time of the year. So case one is a novice snowboarder. So I typically get a letter, 14-year-old snowboarder, injury a week ago, swelling within 12 hours. So immediately I'm thinking this guy's got a serious injury. He had a plain film, which was unremarkable except for an effusion, that's swelling in the knee. An MRI is performed which revealed a small medial condyle fracture and a grade 2 MCL sprain. So the MRI will give you a grade, but really we want to examine this person in our own, get the knee in our own hands, so we can assess it. So it's a very common injury, and they talk about an ACL sprain in the image. So in terms of the history, contact injury turning, didn't hear a pop, so immediately I'm not thinking ACL here. Fell to the ground, couldn't weight bear, removed from the hill. That's often a real factor that someone has to be taken off the mountain by the snow patrol. No immediate swelling, that's good. That the letter did say within 12 hours. Holding the knee in a flexed attitude. Well, that's a position of comfort. So if you have any swelling in your knee, you're going to hold it in a flexed position. Walking with an antalgic gait, so that's the limp. Mild swelling within the knee. 10 to 15 degrees of flexion, of 135 degrees of flexion. So that's holding that knee in a flex position. And the grade 1 injury, in terms of my hands, it differs to the MRI. And the Lachman, which is an assessment of the ACL, was negative. So these are all good signs. So these are the x-rays. So you can see it's a 14-year-old, the growth plates. These are the lines here. They're still open, but no suggestion of any serious ligamentous injury based on any little fragments of bone. So that's a good sign. This is the MRI scan, so this one-shot MRI, and we see over this side of the knee, you've got whiteness, and that indicates some fluid. But this is a minor grade ACL or medial ligament, and this beautiful structure in the middle of the knee, that's the ACL. I spend most of my life dealing with that, and that's a really nice, intact, ribbon-like ACL. So that's normal. So in this person, you don't have to do anything, just get them moving, take them out of the brace and get them going. Really focus on getting that knee extension going, which is fantastic. So this is another case. This is a more serious case, and this is a 42-year-old female. So recreational skier and had an injury to the right knee following the fall. Unsure of the mechanism, but just had a bit of a blur. She felt that both knees kind of went to the side and the ski bindings didn't release. And that was probably what put all the stress through the medial ligament, but also the ACL. And difficulty weight bearing afterwards, immediate pain and difficulty getting off the mountain with gross swelling in the right knee. So, in terms of the clinical assessment, difficult to stand. So, someone's got a serious injury. And on this side, when I examined her knee, that she had what we call grade 3 medial ligament laxity and grade 3 Lachman test. So the knee was very, very unstable in this situation. And what we call ecchymosis or bruising on the inside of the knee. So really had a very, very loose knee. And that was a more significant injury. So that's one we recognize we're going to need to treat and probably treat rapidly. So this is just the image from the side. So I'll draw your attention to the inside of the knee here. And you've got lots of whiteness, which is fluid and blood. And I'm looking for a black structure, but it's all this gray structure here. So there's very little in the way of her medial ligament intact, which is unfortunate for her, but does correspond with what I'm able to assess clinically is that this knee is really at a very serious injury. I'll then show you the image from the side. So what we're looking at on this image is we start from the outside of the knee. We see there's lots of fluid here, which is the white stuff on the outside. As we go into the knee, we see this black structure which lies between the two bones. That's the meniscus or shock absorber. She does have a small tear to that. And then we see the middle of the knee, the ACL. So you can see the absence of a nice ribbon-like ACL. The posterior cruciate ligament's intact and the medial meniscus intact, but then we see lots of fluid on the inside where she's injured her medial ligament. So this is a serious injury in an individual. So this is one we don't hang around with, that we recognize we need to fix this. So these are just some findings from inside the surgery, where you can look in the knee. And this is what we see, and this is the big gap on the inside of the knee. So this is where the inside ligament has been injured, and this is the structure inside the knee. So this is where the ACL is torn, so I'm able to reconstruct that. This is the end of the ACL. And the outside ligament, outside meniscus had a small tear, which I was able to repair as well. And you see that there. And then we'll show you the picture of the ACL. So it's coming in a second. And so this all went very well, but it was appropriate just to get this done at a timely manner. This is a little screw we hold the ACL. This is our lovely ACL in position here, and the knee is able to get fully straight. So this is an example of a more severe injury. And this is what we see on X-ray afterwards. So the ACL is held in place with 2 screws, and I repaired the medial ligament as well at the time. So then I'm going to talk about people who present with more kind of chronic injuries. And this is a guy who came to me in what he called his bandy legs. So he had 2 what we call varus knees. So he's bow-legged. And it's a 62-year-old male, fanatical skier, skis a couple of times every year, and had a mechanism injury where he was twisting his knee getting out of the ski boot. So not a classic kind of dynamic injury, more of a kind of a slower kind of injury with just a twist. And he was able to ski, and he said it settled after a few winds, but did a bit of swelling afterwards. So we see in the knee here, this is the X-ray, which the right leg shows there's nice space between the 2 joints here, but on the left knee, there's very little space. And that indicates that this person has arthritis, and the injury was just an exacerbation of their arthritis. So effectively, what we need to do with this person is do what we call a partial knee replacement. So the partial knee allows us to replace the arthritis on just one side of the joint, which allows that person to get back to good activity very quickly afterwards, and it restores the normal biomechanics of the knee without having to remove any of the ligaments, which is excellent. So this person was back skiing the following season, and it did very well. So the next thing I just want to talk about is joint replacement in the setting of skiing. Oftentimes people feel that their skiing days are over if they require a joint replacement, and that's not the case. And in fact, one of the American athletes in her 40s just won the slalom downhill World Cup slalom downhill skiing with the partial knee replacement. So it's certainly possible. In terms of this person, a 65-year-old male, recreational skier, he refers to it as the best family holiday. It's the time when his teenage children will actually go on holiday with him because he's footing the bill. And in terms of what he was presenting with was progressive pain in his hips, struggled rotating his hip to get his boots on, pain at night. He felt he was waddling, particularly difficult going up and down hills, and wearing ski boots was uncomfortable and unstable for him. So this is an example of his x-rays. So these are both hips. So you can see on the right side, it's a ball and socket joint with a very little clearance between the ball and the socket. The left is a little bit better, but still features of arthritis with extra bone here at the femoral head and femoral neck. So this person had severe arthritis at both hips. He said he didn't want the downtime of having one hip sequentially after the other. So we did both hips. And he was very active very quickly, back driving after 3 to 4 weeks, and he was back playing golf after 6 weeks and was back skiing the following season. So there's no there's no restriction in my mind for someone who wants to go back after knee or hip replacement. You have to be a little bit cautious in terms of your level of skiing. You don't want to go down and do a World Cup Grand or John Slalom if you haven't done it before. So just ski within your level. Okay, so that's it. That just gives you a bit of insight into what I deal with ski-related injuries. But skiing is a great activity. It's great for one's mental health. It's great fun. And I was just tease people as in the muscles that will hurt the most are your stomach muscles from laughing so much. So, but if you do get injured, just be cautious. You get home as quickly as you can, make a diagnosis, and we're very happy to deal with you and get you back on the slopes, hopefully. All right. Thank you very much.
Ryan, thanks very much for that informative talk. Okay, we have a few questions coming in, so let's start now. What's the fastest and most reliable way to diagnose a knee injury? And does SSC handle urgent or emergency cases?
I think the fastest way to diagnose is to take a history, really. As I
Mm.
mentioned, it's a really, you get a very good indication of what someone has done based on just taking the time to speak to them. Most people tend to rely on radiology a lot, but it has limitations and it doesn't allow us to assess laxity or what we can determine with our hands. But MRIs have really revolutionized how we do diagnose knee injuries. So it is certainly part of the package. In terms of urgent knee requests, that I know the GP liaison service within the Sports Surgery Clinic is very helpful that patients can ring and to see if it's appropriate that some of the injuries go to our clinics. Obviously, we don't deal with urgent fractures or trauma, but we deal with most other specialties, including foot and ankle, shoulder, and obviously knee and hip. So the GP liaison service will put the individual in touch with the right teams and will get them seen very quickly
Yeah.
and just take the stress out of the situation.
Yeah, and I think as well, then, if people do have copies of reports or images, if they can send them through or letters, we can then at least show them to you. And then if you can
Yeah,
decide then whether we're the right place or maybe you need to go to A&E when you come back.
yeah, and
Yeah.
like
So,
certainly speaking of our practice, that we have a lot of clinical specialists around all
yeah,
the time. So the
yeah.
person may not get to speak to me directly, but our PAs will
Mm.
put them in touch with a clinical specialist, and we can also organize scans very quickly through the hospital, so that we know we're getting high quality images and that the person comes to us prepared, and we can make a quick diagnosis and then put together a treatment plan.
Yeah. And kind of the next question is kind of on that line, but they're saying, should they get assessed and treated there though anyway, or should they just come home?
Well, it depends on the
And it
severity of the
is.
injury, to be
Yeah.
honest with you. I think most people who have injured themselves, if they're able to ski down the mountain, that's a good sign that it's probably not that urgent that they could wait and to have it assessed elsewhere. And it depends on what time of the week. If they're there for a week, if it's early in the
Yeah.
week, they probably want to get things assessed. And also, it's important that they don't do any further harm. So, getting occasionally using crutches or possibly a brace that's appropriate would be, prudent to get. But it's also just having that, release or just the anxiety that comes with the unknown. And I think having someone who's at least going to be able to make a diagnosis is very important. But I would urge people, there's no situation aside from a limb-threatening injury that you need urgent treatment for. And sometimes people are cajoled or pressured into making a decision. Whereas, if you just contact us, we'd be able to guide you or steer you in the right path if you have any concerns like that.
Great, thank you. From a medical perspective, is there any advantage in having surgery immediately versus delaying it?
Yeah, so this is particularly for the likes of ACL, which I'll take an example. So it all depends on the severity of the injury. Some situations, like I mentioned in my talk, need to be done urgently because their knee is so unstable or very lax. But and the likes of ACL surgery, we much rather a leg that's happy and that's able to move. That's really important for a good outcome after surgery. So there's no huge advantage to doing surgery early doors, and sometimes there's a disadvantage that you get more stiffness. So really, we make a determination on that based on how the knee appears to us when we assess it.
Lovely. Listen, thank you. So if anybody is abroad and they want to contact us, you can do it through the GP line. But if you don't, if you just go on the website and you go into the info line as well, where our GP liaison will pick them up there as well. Brian, thanks for joining us tonight.
Thanks very much. Happy
And
skiing.
thank you. I'm going to introduce Luke Fogarty next, who's our senior MSK physio here. And he again is going to talk about common injuries on the slopes. And Luke will join us afterwards for Q&A. Thank you.
Hi, my name's Luke Fogarty. I'm a sports medicine physiotherapist here at UPMC SSE, and today I'll be discussing the challenges and some of the common injuries with winter sports. So, just a brief overview of what we'll be going through today. We'll be completing a quick needs analysis of skiing and other snow sports. We'll be looking at some of the challenges of these trips, both physical and logistical. We'll be looking at some of the common injuries, and in particular diving into the common lower limb injuries a little bit more. We'll then look at the pathophysiology, we'll look at the risk factors, and then some tips for prevention and rehabilitation as well. So in terms of our needs analysis, skiing is a sport that involves high intensity aerobic bursts coupled with sustained aerobic capacity. So you will have a low level of energy expenditure consistently throughout the day, as well as short bursts of your more high intense activity. Some of the biomechanical stressors involved, so due to the fixation at the ankle, due to the ski boot, this causes immense torque and pressure further up the chain at the hip and knee, and so this is something to be aware of when we're considering the prevention and rehabilitation side of things, as well as some of the common injuries. It also requires a significant amount of core stability and lumbopelvic control. And during our, speed regulation and force absorption, we require a lot of eccentric quad control as well. So some of the challenges with these trips are generally the high density. So when we're away for 3 to 7 days, generally we'll be skiing back-to-back days. And there is a day 3 phenomenon where day 3 is statistically the most likely day that you'll be injured due to the decline in physical and mental performance over the days of the trip. Some of the other challenges are lack of preparation, so poor physical preparation for the demands of the trip, poor recovery. So I suppose Après ski is quite popular, and a lot of people do like to burn the candle at both ends when they're away. And this can result in poor recovery, which limits your capacity for the following days then. Physiologically then, we do have to consider the altitude as well as the cold temperatures. This results in reduced VO2 as well as increased peripheral vasoconstriction. What this basically means is we have an increased rate of muscular fatigue, so our muscles will tire quicker. So if we look at the most common injuries, lower limb we can see is the most common, and of that knee is the most common. We also have upper limb and head and cervical. So some of the upper limb injuries we might see in recreational or elite skiing are our kind of traumatic rotator cuff tears, shoulder and elbow subluxations, clavicular fractures, AC joint pathologies, as well as hand and wrist fractures. In our head and cervical injuries, these will generally be due to impact, so whether that's from falls or collisions, and what we'll see here is fractures, concussion, lacerations, and so on. And I suppose diving a little bit deeper into the common lower limb injuries then, our most common are our ACL, our other ligamentous and meniscal injuries, so MCL and NCL. We've fractures, so our tibial plateau, tibial shaft, and then we also have ankle injuries, which generally tend to be higher in snowboarders, So I suppose due to the recent advances in equipment, thankfully the rate of fractures has reduced significantly. However, our ligamentous, in particular our multi-ligamentous knee injuries, are still quite prevalent. So if we dive a little bit deeper into our ACL injuries, so generally I suppose there's two main mechanisms. So we'll have our contact or non-contact. So our contact injuries are where there's an external force either making direct or indirect impact with the person. So I suppose to compare our pivot sports, which is generally where our most common cause of ACL injury versus skiing. In pivot sports, we'll generally see a lot more kind of lateral compartment bony bruising, and this kind of, I suppose, indicates that the mechanism may be slightly different. So generally in pivot sports, you'll have that pivot shift mechanism, whereas skiing a lot of the time we'll see that we'll have our, I suppose, anterior tibial translation due to our fixed ski boots, and that causes the rupture of the ACL. So generally the mechanism will be axial compression, anterior tibial translation, and then valgus stress and internal tibial rotation. So some of the common mechanisms we'll see are snowplow mechanism. So this is where the tips of the skis come together, the tails come apart, and then the inside edge of the ski catches, causing a valgus force on the knee. We can also see boot-induced anterior drawer. So this is basically where the person lands kind of in a backseat position where their weight shifts backwards, and then due to the rigid boot that shifts the tibia forward, causing I suppose increased pressure on our ACL. We also have our slip catch mechanism. So this would be more common in our elite skiers. So this is generally seen in more high intensity carved turns. It's basically where the inside edge of the ski temporarily loses grip and then catches again, causing the knee to fall inwards while the body continues to rotate. So they're kind of our more common mechanisms. Then if we're looking at MCL and meniscal injury, so I suppose the most common mechanism is our valgus stress and external rotation. And then also in relation to MCL, which is less common but can be seen, we have direct lateral blow as well. And so with our meniscal injuries, we'll kind of see a similar mechanism, and we'll just get that scraping of the meniscus with the femoral condyle. So a lot of the time we'll see these injuries in conjunction with our other ligamentous injuries, in particular ACL. and so it has been identified that a lot of evidence will show that, I suppose, 50% of ACL injuries will have comorbid either MCL, meniscal, or chondral pathology as well. And I suppose a lot of these comorbid or multi-ligamentous knee injuries will more often be seen in elite skiers, and generally it's hypothesized that that's due to, I suppose, the higher energy falls that they would be in due to the increased demand of the skiing that they're potentially doing, or the increased I suppose difficulty. Then if we look at tibial fractures, so I suppose the tibial plateau fractures would be our most common, and so skiing is actually the most common cause for tibial plateau fracture. And so generally this will happen with a valgus and either internal or external rotational force. And so due to the rigid boot again and the long lever of the ski, this will amplify the torque at the knee, and then we'll get that kind of impact of the femoral condyle into the tibial plateau, causing fracture. And so generally you'll see this in conjunction with other ligamentous injuries. We can also get tibial shaft fractures as well. So we may have a spiral fracture where it's a pure torsional force on the tibia. We can also get oblique fractures where we're getting torsion and bending, and then transverse fractures as well, where it's a direct blow to the tibia. And so again, due to the kind of higher energy falls that you'll see in the elite population, this injury is more common for them. And I suppose return to skiing at 3-year follow-up was estimated at around 46%. So it can be quite low, and in the population that did return, it was often at a lower level, and I suppose the rehabilitation process was often quite difficult in these injuries as well. So some of the risk factors for these injuries, I suppose skill level does play a huge role. It's more common. I suppose I've alluded to elite, the elite population being more likely to have your meniscal and chondral pathologies as well as the tibial shaft fractures. However, overall, being a novice or beginner is associated with a higher risk of injury. Another risk factor that is controllable is our neuromuscular control and fitness level. So if we, I suppose, fail to prepare going on these trips and then we're asking of these huge demands on our bodies, often they can fail us when we need them. And then another risk factor is obviously previous injury. Females are at a higher risk of knee injury also. Poor equipment setup, and so I suppose during our falls it's important that we that there's adequate release of our boots and our DIN settings are set properly, so that we're not resulting in that kind of rigid fixation causing force to transmit further up the limb. And so this is why it's important to be quite honest and modest with when you're getting your DIN settings done, because it will stand to you then when you're on the slopes. Another factor then is slope difficulty and conditions as well. So it might be days where conditions are less favourable, maybe stepping down in terms of difficulty level. And then again, it's also being honest with yourself about your level, not to overestimate it. In terms of prevention and rehabilitation, I suppose the big factors are, due to the high density of the trip, can we reduce that? So that's taking breaks during our high intensity periods. It may mean, say, adopting a high-low model where day one you might have a day where you're expending yourself a little bit more intensely. You enjoy your Après ski and then you take the following morning off, allowing yourself to rest and recover and have a shorter session on the slopes. And then the following day you may be a little bit more recovered to go for a longer day again. Another factor then is fuel and hydration. So it's making sure you're kind of eating well, hydrating, and making sure you're topped up in terms of that. And that may mean bringing certain snacks and preparing that for when you're up on the slopes. In terms of physical preparation, completing a block of kind of strength and aerobic fitness work before going. These qualities are things that do take, I suppose, weeks and even months to build. So it's kind of being aware that coming up to your trip, it doesn't necessarily need to be anything extreme, but even a low level of strength and aerobic work in the few months leading up to your ski trip can stand to you then. And then, as I mentioned earlier, accurate DIN settings, so that your boot does release when you are falling, and being honest in terms of your experience level. So that's everything in terms of, I suppose, the challenges of skiing, common injuries, as well as some of the prevention and rehabilitation tips. And thanks for listening.
Luke, thanks for joining us tonight. We have a couple of questions coming up. Some of them, I can combine them because there's a couple of reoccurring themes there. So one of them would be, I have a worn meniscus cartilage from an old skiing injury and surgery's been recommended. If I go for it, will I be able to ski again? So do you want to answer that bit first, I think?
Yeah, 100%. And definitely, I suppose post-operatively people can get back to high levels of activity after either meniscectomy or meniscal repair. So I suppose the biggest thing is having a good planned rehab block, making sure you're kind of progressing through the stages and gradually getting back to everything. And then it's kind of managing load as well. It is something that it can become irritated down the line, but by managing kind of how often you're loading it and the intensity of what you're doing, that can definitely help as well. And I think it becomes more about managing symptoms. So if you do have a flare-up of symptoms, doesn't necessarily mean you can't do an activity. You might just need to change how you're doing it, and then having a good kind of base of strength, making sure the muscles around the knee are kind of supporting you as well when you are getting back to things like skiing or more intense activity.
Yeah. And they are saying, is there anything they can do pre-surgery to help that recovery post-op? Like how would they build up that strength?
Mm-hmm. And it's similar principles that apply. So it's really just having a good foundation of building strength and making sure you're not provoking symptoms. The biggest thing going into surgery is you want your knee to be nice and calm. You want swelling to be in a good position, so that after surgery, which there inevitably will be a little bit of pain and swelling, that it's not already on the back foot going into that. So that'd be the big thing.
Lovely. Now, this one's about knee replacement. Someone's having a knee replacement at the end of May. Again, they're asking about a prehab exercise program that would promote the success of the op. Now, I was just going to say there, whoever on that one is, if you go onto our website and look up the physiotherapy section, we have a whole section on rehabilitation before a knee replacement. So that if you go in there, that might help as well, Luke. Any other suggestions?
And yeah, I suppose like the big thing with knee replacement is generally the joint will be quite irritated. You'll have a loss of range, a lot of stiffness. So I think addressing a lot of those things pre-surgery can help after, because a lot of, I suppose, the big issues we see with knee replacements is if someone can't fully extend their knee or straighten it. So trying to work on that pre-surgery and get that in a good position, that can help after, as well as again kind of building your quad strength and other lower limb strength, just because that's generally what tends to I suppose decondition a little bit after surgery. So
Yeah.
if you have a good base there, it can set you up well.
Okay, and someone's kind of asking, I don't know, if they have a knee replacement, would they get back skiing in around 12 months or a year?
Yeah, and it kind of, I suppose it depends on the level of skiing you're looking to go back to, as well as I suppose your kind of base of strength beforehand. If it's one where you had a good base of strength, like definitely within 12 months, probably wouldn't be going any sooner than that. But definitely if you have a good base and you're kind of following a good structured rehab plan, it's definitely within the realms of possibility.
Okay, lovely. Thank you. So there's the next two questions are kind of similar. So someone's asking about, would a brace help on the slopes, if they have a unstable knee or a different knee injury, or would you recommend kinesiology tape to support the knee for an old injury, or wear a brace?
Yeah, like, it can be helpful, because I suppose we have a lot of sensors around the skin of the knee that I suppose providing some taper support can give us that little bit of feedback that does give us a little bit extra comfort. I don't think it replaces kind of building actual strength around the knee, but definitely can help kind of get you through days of maybe more intensive skiing and stuff like that, and just kind of reduce symptoms a little bit.
Okay. And would you recommend a brace?
A brace, like I suppose it depends on, I suppose, the situation or why you're wearing it. Like if it's one, I suppose the knee is stable enough to go skiing. I think definitely it can be a good adjunct to kind of help
Yeah.
support that a little bit as well. But it is one, if it is kind of highly unstable, it'd kind of be considering, is it a good option? But definitely can be helpful, yeah.
Okay, thanks, Luke. Thank you. So thanks for everybody for joining us tonight. We will send out an evaluation if you could fill it in. It's really helpful when we're looking at what we do in the future. But also we do have our next public talk will be on the 11th of March, and that's for people interested in hiking and walking and the different kind of injuries and preventive exercises you can do for that. So thank you again for joining us tonight. Thank you.